With the patient in exactly the same lateral position, you just keep them where they were, you don't move them after you do the lateral view. You're going to do the L5-S1 spot. You're going to use an 8x10 cassette or image receptor, and your collimation is going to be 4x4 inches, 5x5 inches. It's very tight, very small, and close collimation. L5-S1 joint needs to be right in the middle of your image. In order to do that, you need to center 2 inches posterior to the ASIS and 1.5 inches inferior to the iliac crest. And you will likely have to angle caudally 5 to 8 degrees depending on your patient. When you're doing the regular lateral view, a lot of times the divergent rays will close up the L5-S1 disc space and you can't see through there, and the radiologists want to see through there. So that's why we need to do that extra spot view. Marker, once again, is going to be right in the front anteriorly so it doesn't get burnt out. And you're going to see your greater sciatic notches here. And when I come out for site visits and I'm asking you about this, I want to know what this is. A lot of people confuse that with the acetabulum, but the acetabulum is down here further. So greater sciatic notches, intervertebral foramen, pedicles, intervertebral disc space. This is the wing of the pelvis. So all of these things we'll go over when I come out for the site visits. You're going to still use the lead behind the patient just like we did on the lateral. Nothing is going to change there. Collimation, like I said, 4x4, 5x5, really tight, really small collimation that helps better detail in the image. So when we look at these, I want to see that intervertebral disc space is wide open between L5 and S1. And where's the marker? There's a tiny little post-processing marker there, but I want your marker down here anteriorly, out of the way. AP oblique L spine. Position, the patient is lying down again. Everything's the same as you do with the AP. So you've got 14x17 image receptor. Your patient's going to be rotated 45 degrees to the right, and then you're going to do the left as well because they like to do a good comparison from side to side. You're going to use a sponge to help them stay in that 45-degree rotation. While the book says 45 degrees, a lot of times that's too steep, so you may have to roll them back more like 35 degrees. You'll see when you practice it in lab and in the clinics that 45 might be too steep. It just depends. So you'll get used to it and you'll figure out what works best for most patients. The zygapophyseal joints that you're looking at are the joints on the side down that's closest to the image receptor. Your central ray is going to be perpendicular. It enters the patient 2 inches medial to the elevated ASIS. So the side up, you're going to go 2 inches medial to that at about L3, which is 1.5 inches above the iliac crest. So you need to go a little higher than the crest to make sure that you get up all the way up to L1. Collimation is tight again here, so you're going to be 14 inches lengthwise and 9 to 7 inches widthwise. And these are the Scotty Dogs that you're going to see on the RPO, LPO oblique views of the lumbar. The ear, here number 2, is the superior articular process of L3. The pedicle is the eye, transverse process is the nose, Inferior articular process is the front leg. Pars interarticularis is the neck of the Scotty dog. Back here you can see is the lower leg and a tail. Transverse process back here. This one you can see really well. You can see the eye really well, and the ear really well, the nose, the neck, the front leg. The next slide will show us a little bit better. You can see the Scotty dog. So the neck of the Scotty dog is the pars interarticularis, and it's a very common place for fractures. It's a very, very thin bridge of bone that connects the superior and inferior facets of the vertebrae. So there's a lot of pressure that pulls on that part of the vertebrae that causes it to break down. We'll talk about the pathology of this in another slide. So when you're looking at your images of your obliques, you want to make sure you have good collimation, your marker's not in the vertebral bodies in the anatomy. You want to be sure you can see your Scotty dogs. If you can't pick out the Scotty dog, then something's not lined up properly. So you want to be sure to see the eye, you see the transverse process of the nose, the zygapophyseal joints are the ear and the front leg, and the spinous process in the back is the lower leg, and the other transverse process is the tail. You want to be sure you see all of those. If you don't have the patient rolled right, you're not going to see those. The AP axial view related to the L spine, the L5-S1 intervertebral disc space needs to be opened, and this is one way to see that. So the patient is going to be supine, and you're going to angle your tube cephalad 30 to 35 degrees, depending if it's a man or a woman. Sometimes a man is a little less steep and a woman is a little more steep. It just depends on their lower back and the curvature. So you're going to put your central ray mid-sagittal, 1.5 inches above, centered 1.5 inches above the pubic symphysis, or 2 to 2.5 inches below the ASIS. And your collimation is going to be about an 8 by 10. So when you see that image, what you're looking for is to see that intervertebral disc space at L5-S1 a little bit more open, and you'll see the sacroiliac joints free of superimposition. This is not really very commonly done. It's just done on occasion. It's not, I don't know that I've ever done this one, so you may or may not see it, but it's part of the series that's possible to see. This is what the image looks like. You can see that how the L5-S1 joint space, the intervertebral disc space, is very open. Your SI joints are really open up here at the top as well. Scoliosis radiography is typically the PA and lateral view. Patients are upright because the radiologists want to see the extent of the lateral curvature of the spine. And when the patient's standing, that helps gravity have its effect on the body, and you can see the extent of the degree of angulation. A lot of times they'll do these before a surgery or after a surgery to see the Harrington rods that are in there for support, that they put in for support. Sometimes you'll do bending, which is lateral bending, for looking at the curvatures a little bit differently. Not very often. Typically you're just going to do the PA and the lateral. For the PA scoliosis view, your distance is going to be 60 inches because you want to be able to see the entire spine on the one image receptor. So typically you're going to have a 14 by 36 inch cassette or image receptor specific for scoliosis series. If you don't, then a lot of the new digital equipment has a scoliosis setting that will do them in pieces and then stitch them together into one picture. So the radiologist can still get their measurements that they need, and they won't lose anything in between trying to piece the films together. The way we used to do it was a couple of different films and piece them together. Let's see. Centering, you're going to be at the midpoint of the spinal column where you're centering, mid-sagittal and center of the spinal column. One of the reasons we do the PA is to save the patient some dose. And I found these interesting pictures of breast shields that they have out there now to save the patient's dose to the breast. And there's a collimator aperture that you could attach that has the breast shields attached to it, and also a gonadal shield down here that's attached right to the collimator box. And some of those images were interesting, but you want to make sure that you're not covering up any part of the spinal curvature. 90% reduction of dose to the breast tissue when you do the patient PA. And of course, you want to use any shielding possible. So when you're looking at your scoliosis series and you want to make sure that you've got good images, you want to make sure that you've got at least an inch of the iliac crest at the bottom, and your vertebral column is lined up down the center of the radiograph. That's going to be a little difficult since it's so curved, but you want to be sure that you have everything just in the middle best you can. Here's some images that I found that were just incredible to see some of the curvatures that people have. On the lateral view, they're going to be looking for any spondylolisthesis or any exaggerated curvatures of kyphosis or lordosis, in addition to the scoliosis with the lateral curvatures. Ankylosing spondylosis is a pathology that you may see, and it's kind of an inflammatory process where initially you start with some small erosions on the corners of the vertebral bodies, and the patients have usually a lot of pain and eventually quite a lot of stiffness. And there's then, from the little erosions, it starts to form bridging between the vertebrae, which then hardens like cement and that fuses the vertebrae together. So you just get stiffer and stiffer and very, very limited mobility after the fusion happens. And there's really no way to completely stop it. They more or less just treat the patient's symptoms of pain and discomfort. Spondylolysis and spondylolisthesis go along together. So typically you have your Scotty Dogs here. The pars interarticularis begins to crack and break down. Eventually it can turn into a full-blown fracture in there. You can see it on this x-ray. And then you have the slippage that begins to happen, and that's the spondylolisthesis, where the two joints can't hold themselves together any longer. They just weaken and weaken. Some of the grafting, bone grafting that you'll see in some of your images, they take bone from the hip and harvest it and put it within between the tissues, in between the vertebrae, and take some of the disc out that starts to collapse. They support it with all of this hardware. Some of the videos that I saw are pretty amazing. You should check them out and see what that's all about. A lot of this you'll see on your images in clinic. That's all I've got for the L spine, and I will see you guys in the hospital soon.